Hi, this is Dr. Jonathan D. Hall coming to you from Boston. Today I'm going to talk about things you should know before abdominoplasty, some tips and techniques that I've learned to optimize your experience, improve your healing, and decrease the risk of surgery. So there were more than 170,000 abdominoplasties performed by board-certified plastic surgeons in 2023, according to the American Society of Plastic Surgeons. This was a 5% increase over 2022. So abdominoplasty is one of the most common surgical procedures performed by a board-certified plastic surgeon. As a caveat, all plastic surgeons do things a little differently based on their experiences, so there isn't one right or wrong approach. But these are tips and techniques that I've adopted for my patients over my 34 years in practice. I have arranged this talk as what to consider before surgery, during surgery, and after surgery. If you're one of the many patients considering abdominoplasty, I think you will find this to be very helpful. So many changes have improved patient safety over the last 30 years. Potential complications are reduced, but not eliminated. A hematoma, infection, skin necrosis, wound separation, and deep vein thrombosis. So they're saying that the biggest risk factors for abdominoplasty are age over 40, obesity, and smoking. You can't change your age, but you can reduce your weight before surgery, and you can stop smoking. Patients that have lost 100 pounds or more have a 130% chance of some complication, which, if you do the math, would suggest more than one. So we want to do things together with our patients to reduce the risk as much as possible, but be around to help get them through the issues that do happen. So most important is no smoking or vaping. A single cigarette in the month before surgery can double the risk of infection and wound breakdown and skin necrosis, which is really a shocking statistic. So don't smoke. People used to think that maybe vaping was safer, and it possibly, but it still increases your risk of wound healing complications, and so you don't want to be vaping or smoking. I have my patients stop at least 2 months before and 2 months after surgery, and if they're not able to stop smoking, I would not do an abdominoplasty. So let your doctor know if you've been a smoker or a vapor. So I mentioned obesity is one of the big risk factors, and body mass index is a measure of your percentage of body fat. You can look up BMI calculators online and put it in your height and weight to see where you are. So being at a more optimal weight is another thing that you can do to improve your healing and minimize your risks. So this is a BMI chart, and I put an arrow here around 28. So I found through experience that I like my patients to have a BMI of 28 or less. Some docs go up to a BMI of 30, but I think 28 is good because if you gain a couple pounds after surgery, you're not going to immediately have a problem. And for most patients, that's even though they're a little overweight at a BMI of 28, we're able to do an abdominoplasty successfully. You can see in the pictures that as the patients get heavier and heavier, they show that the stomach sticks out more and more. And why is obesity a major risk factor? I tell my patients that you can run a marathon if you want, but you have to get in the proper shape first. And having an abdominoplasty is no different. A little overweight is okay, but once the BMI is more than 28, there's typically more fat inside the abdomen as well. I tell my patients you can't put 40 pounds of potatoes in a 20-pound bag. So there's fat around the intestines called mental fat. And if there's enough fat or enough potatoes in the bag, you can't tighten that abdominal wall without increasing the intra-abdominal pressure. As you increase the intra-abdominal pressure, not only do you increase the risk of a blood clot because it compresses the deep veins that go through the abdomen, but also the top of the abdominal cavity is the diaphragm, so it makes it harder to take a deep breath after surgery. So if you're higher than a BMI of 28, reduce your weight first. There are some exceptions for patients that have had an extraordinary amount of weight loss where we can use a slightly higher BMI depending on where they're holding their fat, but usually a BMI of 28 is a good starting point. So the next thing is optimize your nutrition. I have a separate video on how to optimize your nutrition to help heal better after plastic surgery, and if you're interested, you might find that to be helpful. But optimize your nutrition starting 4 weeks before surgery. So protein supplementation is one of the most important if you're post-bariatric surgery, weight loss from semaglutides, or have a BMI less than 18. Vitamin C and vitamin D can also be helpful. But again, the most important in my experience is protein, if you might be deficient. So interestingly, the recommended daily requirement of protein is 1 gram per kilogram a day of healthy body weight, and more is needed to heal, as much as 80 to 90 grams a day more. So a kilogram is 2.2 pounds, and if you're a 70 kilogram woman, which is 154 pounds, then you need 70 grams of protein a day just to be healthy, not counting surgery, and you'll need more protein to heal. So discuss with your surgeon, but for my patients, I strongly consider high quality whey protein. Again, if they're going to have surgery and have previously had bariatric surgery or lost significant weight with semaglutides or have a BMI less than 18. And again, I recommend it starting 4 weeks before and continuing 4 weeks after surgery. Two consistent favorites are Premier Protein and Fairlife Protein. So I have my patients taking 80 grams a day for 1 month before and 1 month after surgery if they're at risk, and this has really helped with the healing. So one of the other risks with abdominoplasty is infection. And I noticed early on that patients had started to get a little red or a little junky looking around their belly button. And I went to a meeting and somebody had an umbilical cleansing protocol. So about 15 years ago, I started my patients on an umbilical cleansing protocol. So what we do is we have patients wash with HibaCleanse, which is a prescription soap, wash the abdomen and the area daily, starting 5 days before. And then we get mupirocin ointment, which the brand name is Bactroban. We have our patients place that in their nostrils and in their umbilicus 3 times a day for 5 days before. So people ask why the nostrils as well. Well, patients can be carriers of methicillin-resistant staph, and it tends to live in the nostrils. So putting this in the nostrils and the umbilicus really has cut down on the risk for infection. So ERAS means enhanced recovery after surgery. So there are things we do to try to help our patients have a better experience and heal better after surgery. One of the things I'll do is have a warming blanket applied to our patients, and we start this in the pre-op area. One of my professors from medical school, Dr. Leroy Young, showed in his book on decreasing complications after plastic surgery that pre-warming patients before they get to the operating room really cuts down your risk of infection. That makes sense. Your mom always told you not to get chilled if you went out to play outside. And when we take patients to the operating room, we put them to sleep, and then part of their body is unclothed while we're prepping and draping, and so they can drop their core temperature. If we heat people up before they go to the operating room, their core temperature doesn't drop. There's not as much stress, and they've proven a lower risk of infection. I have my patients get oral Celebrex preoperatively. It's a selective non-steroidal anti-inflammatory that seems to work very well for pain. We give patients acetaminophen, which is the generic name for Tylenol, and we either give it pre-op orally or intraoperatively through the IV. And then during surgery, I use a long-acting local anesthetic such as Marcaine, as well as Exparel, liposomal bupivacaine. It should have one L there. So there are other ERAS protocols. Some doctors use other medications such as gabapentin in their protocols and regional nerve blocks, but I haven't felt that these have been necessary in my practice and haven't been benefits haven't been worth the risk. So tranexamic acid. So another risk of abdominoplasty is hematoma, and tranexamic acid is a lysine derivative that inhibits fibrinolysis and blocks bleeding. So that's a mouthful, but basically when we cauterize a blood vessel or we stop bleeding, the bleeding stops, there's a little clot, but then later that clot can break down and patients can start to bleed again. So this blocks the receptors and prevents that rebleeding from happening. It blocks fibrinolysis. This is an article that's recently been accepted for publication with one of the co-authors, Dr. Rod Rourke, who trained just ahead of me at the University of Michigan. And they systematically reviewed 45 studies using TXA in plastic surgery. And they note there have not been specific studies yet in abdominoplasty to prove that it decreases the risk of hematoma, but it is shown to do so in other procedures. Knock on wood, I've not had a hematoma after an abdominoplasty in the last 4 years that we've been using tranexamic acid. And they note in the article that there is high certainty evidence to support the use of TXA in cosmetic surgery, and they're looking for other studies specifically to be done. So Exparel has become for me an essential part of my ERAS protocol. This is a liposomal bupivacaine or liposomal Marcaine, and it's injected at the time of surgery. It decreases the risk for narcotics after surgery by 70%. The majority of our abdominoplasties now are done as an outpatient. And most of my abdominoplasty patients are able to manage with ibuprofen alone. The difficulty I've found with Exparel is it's not intuitive for most doctors to learn how to use it. Now, as a disclaimer, I was a paid trainer for Pacira Pharmaceuticals. They're the company that makes Exparel. Shortly after Exparel first came out in the mid-2012. I did this for 2 years. I haven't for years been a paid trainer for Exparel due to time constraints, and I no longer have any financial interest in Exparel or Pacira. I was at a meeting where a doctor was giving a talk on his technique for abdominoplasty, and he said during his talk that Exparel didn't work. And a female plastic surgeon sitting next to me leaned over and said, "That's a bunch of hooey," because she had had it for her abdominoplasties and it worked great. And I found that it works great too, but it took me about 2 years to learn how to use it correctly, and it's just not intuitive for most surgeons because it doesn't respond like our normal long-acting local anesthetics. So the doctors that say it doesn't work generally are not injecting it correctly. I have a separate video that shares my technique for docs that want to learn how to use it better. I would personally not want to do an abdominoplasty for a patient now without Exparel. So this is a typical abdominoplasty if there is such a thing. I'm working on a separate video that talks about some of the variations of abdominoplasty that I use frequently. These are the Plastic Surgery Society diagrams of a typical abdominoplasty. First, the scar is marked to be hidden by a bikini bottom. The skin is undermined up to the rib cage. This undermining now really tends to be more limited laterally to better preserve the blood supply and allow liposuction if needed. So the artist diagram is sometimes a little bit less, just over the rectus muscles. Then we repair the muscles, the diastasis, the rectus muscles that are stretched out by pregnancy and weight gain, and then we remove the excess skin like pulling down a window shade. So when I was trained at the University of Michigan, we used permanent sutures in 2 layers to correct the separation of the rectus muscles called a diastasis. And I show on this diagram here the muscles being brought back together. But occasionally, after being out in practice, I would see a suture granuloma. So it's a suture that gets some bacteria on it, it's kind of chronically festers and chronically infected, and would start draining months or even years after surgery and need to be removed. So several years ago, I started using only absorbable sutures, but still in 2 layers with abdominoplasty. This is a nice review article that came out in 2020 that gathered 35 studies describing 45 different techniques of diastasis repair, and this confirmed what we're doing, that resorbable sutures don't affect the complication or recurrence rate of the diastasis. And they still say yes to a double layer of suture repair, as we were taught. So my feeling is if there's no benefit of permanent sutures with the diastasis and they add a risk of late suture granuloma, I now avoid them. Seroma, which is a fluid collection, was the most common complication after abdominoplasty. And you think about this, if we have this whole area lifted up and this whole raw surface area, it's like your knee's been scraped and fluid kind of comes out. All that fluid's kind of weeping out, and it's got to get glued back together with the healing process. So this article came out in 2004 and was very important and showed that quilting or percussion tension sutures can be used to dramatically decrease the seroma rate. And so this shows, I know the picture is a little bit small, but we put these in at certain intervals. Some people use a running barb suture with this, but it basically tacks the deep surface down in several spots. So it keeps that abdominal wall from shifting as you're moving and helps to prevent the fluid from accumulating. So a lot of doctors are reluctant to use these at first. I was as well. But after using them and seeing the dramatic improvement in seroma rate, I wouldn't live without them. So they've become an essential part for me of abdominoplasty, quilting sutures or progressive tension sutures. So after surgery, this is pretty standard, an incentispirometer. It's a little thing with 3 balls, and we have patients work to take a deep breath, and it helps to keep the lungs expanded. So it decreased something called atelectasis, which is a little alveoli starting to close down after surgery. And if that persists, then patients can get pneumonia. So I'll have the nurses send one home with our patients, and I tell my patients to use it 10 times every time a commercial comes on television or they get to the end of a book chapter. So after surgery, I have patients get up and walk each hour a little bit around the house. This keeps the blood from flowing in the legs and decreases the risk of a DVT. But recovery after surgery is not the gym. It's not no pain, no gain. The time to push yourself is when the calendar says 6 weeks. You've got to give the tissues a chance to heal. So I tell people to walk, but don't spend too much time twisting. Of course, you have to kind of turn and get out of bed, but when you're turning, turn slowly, more like a log. Avoid a lot of twisting at the abdomen and give your tissues time to heal. Don't push the healing. So I gave a talk at my kids' school when they were in the 3rd grade, and I said, does anybody here know how long it takes for skin to heal? And a little girl held up her hand. She said 6 weeks. I was astounded. And I said, how did you know that? I've been trying to tell my patients that for years. And she said, well, my brother Timmy had a broken arm and he had to wear his cast for 6 weeks. So I thought if bone takes 6 weeks to heal, then it probably takes skin 6 weeks to heal too. I thought, astounding. That's a smart little girl. So basically, wounds actually drop in strength for the first 3 weeks, and then slowly they start to get stronger from the 3rd to the 6th week. So by 6 weeks, things are back to 70% of the final wound strength. So that's why 6 weeks is kind of the mark where all of a sudden, okay, the answer to most questions is 6 weeks. Sex, going to the gym, running, jogging, bending, twisting. And so give yourself 6 weeks to heal, and you'll heal better and have less problems. So after surgery, I usually have patients wear a micropore tape for the first 6 weeks and keep a light gauze over the umbilicus. There is a product called Embrace, which is a tension-loaded silicone patch that you change every week starting 2 weeks after surgery. I've not found it to be necessary in the majority of my abdominoplasty patients, and it can be a little fussy to use. After 6 weeks, I typically recommend topical silicone. Now, the other important thing is to avoid exposure to the sun, UV exposure, especially around the umbilicus. Something about that umbilical scar, any scar that's pink, if you expose it to the sun, can turn brown. But if you go to the beach and you cover your lower scar with your bikini bottom, but you get your umbilical scar in the sun, it can turn brown and get darker. And there are bleaching creams that you can use, but just better to avoid sun exposure in that area for the first 6 months to a year. Keep some zinc oxide on it or keep it covered. So that's called post-inflammatory hyperpigmentation. Now, you're going to have some swelling of the abdominal flap on and off that takes about 6 months to go away. So if you eat a bag of potato chips, have some salty diet, you're going to notice a little more swelling the next day. It kind of comes and goes. I've had patients that have gone for lymphatic massage. I think if you go for lymphatic massage, don't go for lymphatic massage. I think 6 months later the swelling's better. So I'm not sure it's worth the extra money to do that. But I do have my patients wait 6 months for heavy abdominal core strain, like sit-ups on an incline board. So this has been Dr. Hall coming to you from Boston. Today we reviewed tips and techniques to help you have a better abdominoplasty experience with less pain, better healing, and decreased risk. So don't smoke. Reduce your BMI to 28 or less. Optimize your nutritional status before surgery, especially protein if you've had bariatric surgery, weight loss with semaglutides, or low BMI. I recommend an umbilical cleansing protocol to decrease the risk of infection. I've discussed my ERAS, Enhanced Recovery After Surgery protocol, to enhance your recovery after surgery, including the use of Exparel, which is a liposomal bupivacaine. I no longer recommend permanent sutures be used for the diastasis correction to decrease the risk of late suture granulomas, as we reviewed. The studies showing that absorbable sutures work just as well. We talked about progressive tension sutures, or sometimes called quilting sutures, which have been shown to decrease the common complication of seroma. We've also reviewed the importance of walking after surgery, but avoiding excessive activity for 6 weeks, and why that is important. We talked about avoiding sun exposure to prevent darkening of your scars after surgery, especially the umbilicus. And I talked about the benefits of topical silicone to help with scar maturation. So thanks for listening, and I hope that you found this to be helpful.